Welcome to Equal Dose, the podcast that delves into the social determinants shaping our health and uncovers strategies to improve health outcomes for everyone. I'm Autria Godfrey, speaking with you today from Washington, D.C.
And I'm Stephen Horn, joining you from London. In each episode, we explore key issues affecting our collective well-being and discuss steps towards enhancing health equity across diverse communities. Join us as we bring you expert voices, impactful stories, and initiatives that are making strides towards a healthier, more inclusive world.
And Stephen, it's important that you brought up inclusive because today we are looking at disability. And disability is an interesting topic due to the inevitability of it. We will all almost certainly experience disability at some point in our lives, even if it's just through old age. In fact, the CDC suggests that over 1 in 4 adults here in the United States have a disability. Before we get into today's program, we want to make this disclaimer. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they may have and should seek the assistance of their healthcare professionals for any such conditions.
Coming up on the show today, we speak to Professor Michelle Meade from the University of Michigan about better aligning healthcare systems and services with the needs of people with disabilities. And we speak to Sharon Milberger and Jaime Junior from Michigan's University Center for Excellence in Developmental Disabilities Education, Research and Service about shaping policies and creating accessible communities. And I'm delighted to be joined by Laila Rizvi, who's our Director of Research and Strategy at Web's Edge, behind the podcast. Big subject today, Laila.
Massive subject. And I think people underestimate the broad demographic that disability encompasses. Like Autria alluded to, we all are very likely to be affected by a disability. And I think this shouldn't be underestimated. And I also think that when we think about a disability, we perceive it to be a medical issue, but there's a whole load of social issues which also come with having a disability.
I mean, I think one of the things that disturbs me about it as well, there are lots of things here that disturb me, but one of them is the amount of money it actually costs disabled people to access healthcare. Their out-of-pocket expenses are way higher than for the rest of us.
Helping people with disabilities is beneficial for us all, as in it's a universal goal which has universal benefit. And if there's a high economic cost to it as well, that's not of benefit to us, as in we don't want to be hemorrhaging money as a society on something which is easily preventable and solvable.
Autria, what's your take on this?
I couldn't agree more, and I think Laila brings up a good point that, you know, when you take care of a situation where someone with a disability needs something corrected or something fixed, it might be that you end up benefiting from that in the long run. For example, after I had one of my children via C-section, all of a sudden I paid very close attention to where there was a ramp versus stairs that I had to take. Once you experience a disability, even if it's temporary, your eyes are open to that. There was also an American Medical Association 2021 to 2023 report that described ableism as one of the root causes of health inequities, but it's generally underrepresented in medical community discussions.
Ableism is a structure of power that classifies disabled people as somehow less than and creates structures that advantages able-bodied people.
Deep roots in United States history. In fact, the landmark legal case Buck versus Bell back in 1927 allowed for the forced sterilization of an 18-year-old girl, and this has still not been overturned. The 2022 National Women's Law Center found that forced sterilization of people with disabilities is still legal in 31 states. We are joined now by Sharon Milberger and Jaime Junior from Michigan's University Center for Excellence in Developmental Disabilities Education, Research, and Service. Thank you both for your time today.
Thank you.
Good morning.
So Sharon, you spent most of your professional life working for people with disabilities. Could you tell us a little bit about the focus of your work today?
For the majority of my career, I focused on public health and disability. And there have been times during my career where I have been in healthcare more broadly. And in those situations, I've always been struck and frustrated by the fact that disability isn't on the radar for healthcare systems in terms of access to care, quality of care, or even their diversity, equity, and inclusion initiatives. And so today my focus has been on improving access to health care and promoting health equity for people with disabilities. And a few years back, and this was during COVID, my organization received a large-scale grant through COVID relief dollars in the States aimed at populations that have been disproportionately impacted by COVID-19. And we know that includes people with disabilities. So we partnered with a couple of other organizations, statewide organizations, that work with people with disabilities. Because we had the same goals and objectives, same target population, we decided to work together to optimize our collective impact. And so what we did is we created a set of criteria for healthcare organizations to become a most valuable provider or MVP certified. And that designation signifies that a healthcare organization is accessible and welcoming to people with disabilities and their families.
So what can organizations such as your own do to help draft policy, to help sort of get stuck in there to make communities more accessible?
Well, our organization, as mentioned in the intro, is a UCEDD, or University Center of Excellence on Developmental Disabilities. UCEDDs are federally mandated, and every state and U.S. territory has a University Center of Excellence on Developmental Disabilities. So we are part of a network of 67 centers, and what we are working on is systems change, and that we are trying to simultaneously address the multiple barriers that people with disabilities face. And so these include creating disability training so that addresses some of the attitudinal and barriers that people with disabilities face, ensuring a site is accessible, physically accessible, ensuring a site is sensory friendly, so addresses things like sights, sounds, and smells. And also the site asks about disability status. And then if a person identifies as having a disability, they ask about accommodation needs. So by doing this comprehensive approach, that can create a more welcoming environment for everyone involved. And because UCEDDs are well recognized, so in our state, we are well positioned to partner with other organizations, as well as being nationally recognized, we're hoping to create a national model.
Dr. Milberger, I wanted to go more into kind of public perceptions of disability and ask you, from your perspective, how do you envision public perceptions of disability changing, and what do you think needs to be done to create more inclusive and equitable systems, particularly in terms of housing and healthcare?
I think the public perceptions of disability are changing, but very slowly. And historically, particularly with medical care, that in health systems, there's been an emphasis on a medical model of disability, where disability is viewed as something wrong with someone, something that needs to be fixed. And with time, we are moving towards a social model of disability, where disability is viewed as a natural part of the human experience. So I think that is a very positive movement, but that change is slow. We need to collaborate together with the same vision and mission in mind, and partner with other organizations. And we also need to keep in mind that a lot of the approaches that make healthcare more accessible, or just the community more accessible, are good for everybody.
Jaime, I'd like to bring you into the conversation here. I see you nodding along with Dr. Milberger and some of the things that she's saying. I do want to talk about the incredible work that you've done and all of your accomplishments in just a moment. But I'd really like to have your personal perspective on how do you think we're doing when it comes to making these changes and seeing some advancement and growth?
Well, I agree with Sharon, my colleague Sharon, that there's a lot of work to be done. I would add to her sentiment that it's really important that individuals most impacted be at the table. That's the same in any DEI space. And I kind of like to call it DEIA, to center accessibility, because as Sharon mentioned, what's good when you're creating a good environment for individuals with disabilities, everyone benefits. It's that way. It's been that way throughout history. Think about curb cuts, right? They were originally thought of to help people with wheelchairs get up on the sidewalk. But people with strollers, people that are delivering packages, benefit from curb cuts. And so I think making sure that people with disabilities are at the table in a meaningful way. For instance, in Michigan, we've done something unique with community health workers. We had a program through our state's Developmental Disabilities Council, which is part of the DD system, which the UCEDD is a part of, to create a position for a community health worker that has a great understanding of disability to be a part of the health department in Detroit. So that's a way to create positions that put people with disabilities in leadership roles, decision-making roles, but it also keeps us top of mind, because you're less likely to discriminate against your coworker, against your neighbor, because you see them in a different way.
I'm glad you brought up Michigan, because I want to talk about some of your accomplishments, from earning your degree to becoming 2023 Miss Wheelchair Michigan. What has been your driving force behind your advocacy work, and how do you balance it all so well?
So, the driving force behind my advocacy is really systems change and creating a better world for those that come behind me. I really want to build a more inclusive space where disability is truly seen as part of the human condition, and the diversity that it brings really opens up new possibilities in the world. And the way I balanced it all is really to marry the two. So in that, I'll say my advocacy sometimes is not separate from my life. I'm an advocate through and through, so whenever I go into a space, I always say whatever space I go in, I bring me with me. So just by being there, being present, being vocal, being intelligently articulated, I'm changing the conversation.
When you talk about some of your advocacy work, is there anything in particular that you're working on right now when it comes to economic self-sufficiency or accessible housing or even transportation that you'd like to highlight?
So it's interesting that you bring up transportation. Right now in Detroit, I'm working with a social justice group called Detroit's People's Platform to really advocate for more environmentally friendly paratransit vehicles. Right now we have what's considered a hybrid system in our city, and a lot of the vehicles are older vehicles. In Michigan, we don't have to have our vehicles inspected for energy or for carbon emissions like some other states or countries do. So it's important that we start moving toward more energy efficient vehicles for paratransit in our city. We were successful in getting our city to pass a resolution that when it starts renegotiating our contract, that we will make sure that energy efficient vehicles are part of that conversation and part of the contracts. So that's an example of something that I'm doing in the transportation space.
Thank you so much for sharing your story and experiences, Jaime. I wanted to get onto what messages you would share with people who might be facing similar challenges, and particularly young people with disabilities, and their efforts towards trying to reach their own personal goals, and what advice that you might give them.
I think the best advice that I could give is be true to yourself. Because if you have an area of your life that you're passionate about, advocate for that. And again, just by showing up, you bring you with you to the party, and you make your needs center stage, just like anybody else does. When you ask for accommodations, when you state your needs, when being invited somewhere, you make people aware that everyone has needs. Our needs aren't special. They're just unique as we are.
Can I jump in and ask both of you a question? We were just recently at the American Public Health Association conference in Minneapolis this year, I think it was. And one of the big issues that has been coming up time and time again this year has been the issue of trust. And in our community, but in our public health systems. And I wonder how you think disabled people, what trust they have in public health today.
Distrust in the healthcare system is prevalent for people with disabilities, and unfortunately, rightfully so. You know, we've kind of touched on some of the barriers that people with disabilities face, the medical model, and there's also recent research showing some of the provider biases. There was a recent study looking at U.S. physicians nationwide, and in the survey that they conducted with 714 physicians, 82% reported that people with significant disabilities have a worse quality of life than those without disabilities. So you can imagine that statistic alone, that if the provider thinks the person has a lower quality of life, you can imagine what kind of care they would receive or not receive with that kind of attitude. The study also showed that only 40% of the physicians felt very confident in their ability to provide quality care. Only 50% agreed that they would welcome patients with disabilities into their practice. These statistics are really disturbing. They impact the disparities we've been talking about. So I think that there's a lot of work that needs to be done to rebuild or build trust with providers. With some of the strategies we've talked about.
Can I ask a question? I mean, that mindset seems to fly in the face of the Hippocratic Oath, which all physicians take. I'm shocked by that. Is there not enough a training or curriculum that specifically addresses people with disabilities when they're going through med school?
There's no requirements when going through med school. We, through our organization, and Jaime and I have worked together on providing training, but it's not required, and most physicians get no training. It's one of the prongs of our strategy. It's not the only thing, but it is a critical piece to have that training.
It's really about physicians providing culturally competent care. I am a person that believes that disability absolutely is a culture, and as such it should be taken under consideration when you are delivering care. Sharon alluded to the quality of care. A lot of times things are misdiagnosed because of individuals with disabilities. I can give a personal example. I have been going through some swelling. I have some swelling in my legs. And they attributed to the fact that I use a wheelchair, so my legs are typically immobile. But through further examination, what was found was that I have venous insufficiency and some fibrosis that is treatable, but because it was not addressed the same way that possibly someone using their legs to emulate would have been addressed, it could have possibly resulted in me losing a limb.
I mean, I want to just point out that here in the United States, the CDC suggests that more than 1 in 4 adults in the United States have a disability, and that at some point over the course of our life, we will all experience some sort of a disability, whether that be just to old age or some sort of a temporary disability.
You know, the 1 in 4 in the U.S. with a disability is over 70 million people, and worldwide it's over 1.3 billion. So we're not talking small numbers. So it's a huge issue.
When Sharon talked about the medical model versus the social model, that's really key to making better outcomes for people with disabilities. If you see disability as a medical condition to be fixed, then you don't address a person's social emotional needs, psychosocial needs, and all those other things that impact their health. I mean, the way that a physician speaks to you impacts how you will receive care. In a lot of circumstances, for instance, something like cerebral palsy, and I use cerebral palsy because that's my disability, that's my experience. It does not necessarily impact my health in that it's a health condition to be treated, but it impacts my health because some of the social things or elemental things in my life are affected by my cerebral palsy, such as ambulation, such as how sedentary I am because I use a wheelchair. These things are not necessarily health issues to be treated, but they impact the way that I receive care.
As we look to the future, and I know that you both agree that there is a lot more work to be done, what actions would you advocate for that you think would have the most significant impact on health equity for disabled individuals?
People with disabilities have numerous health disparities they experience, whether that's diabetes, stroke, heart disease, cancer, depression. And we must address these disparities. I think COVID shed the light on some of these disparities, and that's a silver lining in a way. One thing I didn't mention that I think is an important part, and I'm so glad, Jamie, you said about making sure that people with direct lived experience are part of the solution. That is critical. Another part is that we need to ask disability status. I have found that in healthcare, disability status is not asked, and I think people feel uncomfortable with that. But if you don't ask disability, you can't know what accommodations might be needed. You can't measure what disparities exist. And there's a saying in public health, we measure what we treasure. So we have to be asking about disability status. We have to elevate it to how we would ask other routine sociodemographic variables like age, race, sex. So I think with that comprehensive approach, with strong collaboration, I think we can go a long way with an emphasis on the social model.
All right. Well, our thanks to you both for being with us today and for sharing, your experiences and all of your advocacy work, and also Jamie for you sharing your lived experience. We really appreciate your perspective and your time today. Thank you.
Thank you.
Thank you so much.
What fascinating guests, right? And that the line from Jamie, was just will stick with me a long time, right? Which is, I bring myself into the room.
Yeah, and I think it really highlighted that, disability is not a problem that we kind of push in the corner and is separate from everything else. It affects everyone else firstly, but also it's not this medical problem that needs to be solved and then it goes away. It intersects into everything else. And they really kind of showcased how disability impacts care to other things, such as COVID, such as heart disease, such as diabetes. Disabled people deserve care in those regions as well. It shouldn't be that their disability kind of blurs those areas.
Both Sharon and Jamie recognised that providers don't want it to be this way. So they're not doing this because they don't want to provide that care, but the disability seems to be a block to them that they're somehow not trained, that the systems aren't designed for. So this is creating a lesser environment, a lesser standard of living for a lot of people, and nobody wants it to be this.
It sounds like there are these unconscious biases about, well, I'm not really properly trained in the best manner to help this person, so I'm just not going to, which certainly is not the answer. So it sounds like there are some systemic factors at play here that need to be addressed.
Well, surely aren't we all involved here, and don't we all have a responsibility to try and see exactly what you were saying, Laila, that the disability is not a medical issue to be solved, and that we need to make sure that disabled people are included?
Well, we are going to get one more expert to weigh in. Earlier, I spoke to Professor Michelle Meade at the Center for Disability Health and Wellness at the University of Michigan. Let's take a listen. Michelle, thank you so much for your time today.
Thank you so much for having me here. I'm delighted.
All right, I'd like to get started with you sharing more about your role at the Center for Disability Health and Wellness, and also what drives your research focus.
Okay, first let me start with an introduction. I am a middle-aged white female with short graying hair, freckles, and glasses, currently wearing a blue top and a black pinstripe blazer. I'm trained as a rehabilitation psychologist, a researcher, and I'm a professor in both the departments of physical medicine and rehabilitation and family medicine here at the University of Michigan. I'm also the founding director of the U of M Center for Disability Health and Wellness, or CDHW. CDHW was really developed to allow us to develop long-term collaborations with both our interdisciplinary colleagues, so folks in engineering and information, in medicine, in public health, across disciplines, as well as with the community. We want to make sure we weren't doing helicopter research, that we wouldn't go in and try and get something from the community without giving something back. Our approach is one of holistic collaboration. So we're conducting research, but we're also doing a wraparound translation to both provide training for the next generation of researchers, to enhance the field, as with whatever the needs of that community and the concerns, and providing back what we can. My own research is really driven by the voices, the experiences, the narratives of both friends with disabilities, of family members, of research participants, and of my patients. And so really thinking about how do we better understand health and healthcare equity for this group, and how do we go about making changes?
Right. It's interesting that you call it helicopter research. I've never heard it referred to as such, but that makes such great sense. And I would think that avoiding that type of research and instead focusing more on that integrated type of research gathering, that your results are much better and much more understandable, and that the conclusions that you're able to come to can be much more easily implemented.
I hope so. One of the things we often hear in research is that it often takes like 10 years for research findings to be integrated into clinical practice. What we're doing here is, figuring out what the best practices are, why things happen, and then also think about how do we apply this right now? How do we advocate for better practice?
Your center's mission statement mentions that the healthcare systems currently don't really align with the needs of the disabled community. Can you expand on this and kind of give us some examples?
Often the healthcare system is developed based on cost effectiveness. And so we try and get as many people in the door as most convenient practice as possible. We use steps like education, like lining up many people in the waiting room or online, without necessarily thinking about, is the person able to get online, or are they able to tolerate being in a crowded waiting room? In my work in self-management, one of the things we talk about is adherence, or what you hear is, are they adhering to practice? How are they managing their illness? And what the healthcare system often wants to know is, are they doing what we recommend? We've given them a set of instructions. How are they implementing them? Rather than thinking, what are the things going on in their life, and how are we helping and partnering with them to kind of face those challenges to get to the outcome that is most important to them?
So it sounds like some of the most pressing barriers to care are happening almost before they even see a physician, before we get to the medical component of it.
Oh, definitely. I think we have to realize that health happens in the community. It happens in the home. Mm-hmm. The management and the gatekeeping of the health system is allowed to do often happens in the office. We prescribe medication, we give a referral to see another specialist, we get therapy, but health is about behaviors and how we take care of ourselves, and figuring out also how to work with that provider, can be challenging, especially as healthcare systems get bigger and separate the provider more from the person in the room.
True. Do you feel that ableism appears within the healthcare sector, and do you think that there are implicit biases that are at play here?
In so many ways. So yes, that healthcare inequities are often associated with ableism. We don't think about including the individuals with disabilities. We somehow think that they don't have the background or understanding or ability to participate as an equal partner in their care. We don't think about setting up environments in ways that allow them to be fully present and to feel comfortable. We may not even think about, having the equipment available to get them on the table, to provide them with the same type of care. And so there is the type of systemic or ableism that results in environments that aren't accessible. And then there's the discrimination and implicit bias, which makes us not aware as healthcare providers of the various factors that influence their lives, or of kind of us questioning their right or ability to be informed and to participate in the decision-making process.
That was something that we spoke with another interviewee about, and the high percentage of doctors and physicians that kind of have this mindset about when it comes to quality of life, which really blows my mind, because you would think that there would be some sort of curriculum or training during their medical school days that would really chip away at that bias that I guess we all kind of bring to the table.
And unfortunately, most medical students maybe get a few hours of training related to disability at most.
Yeah.
Although I do think there is an increasing movement by medical students to say, no, this is important. How can we get this in our system? How can we hear more about this and collaborate with the community?
Good. That's some progress. Oh, speaking of movements, you actually teed me up perfectly, because I want to talk about the Americans with Disabilities Act. It's been around since 1990, so it's been around for decades, and it has been crucial for disability rights. But are there still gaps? And if so, where are we falling short, especially when it comes to the context of public health?
So we have to remember that the Americans with Disabilities Act is kind of the lowest bar.
Okay.
It just is about getting people in the room. Also, for decades, its enforcement required individuals with disabilities or their representatives to make a complaint, that there wasn't a standalone body or there wasn't a mechanism for enforcement without that. And so it required a lawsuit. And that then meant that an individual with a disability had to balance. Is it worth alienating my provider? Is it worth, not, or coming up with a lawsuit to this organization or business or system in order to allow me to get in the door? Would I even be welcome then? And so as that comes to healthcare, this is a service that many individuals with disabilities need. This is their access to medicines. This is their access to supplies. This is their care that we're talking about. And so they need to be partnering with a healthcare provider and system for the very basics of life. Putting that then enforcement, making it dependent on that, is one of the, I think, key challenges or problems that came up. Also, the Americans with Disabilities Act, while it may mandate certain requirements to allow people in the door, or so many parking spots, or online accessibility, it doesn't mandate the accessible equipment. And so whether or not a diagnostic test is available, whether or not there are things in the hallway that prevent someone from getting in comfortably or navigating independently, are maybe recommended, but they're not enforced. More of this has been done with the Affordable Care Act and some of the 1557 and some of the other components of that, which are doing more to say, well, physicians and healthcare providers and systems should be aware. They need to be aware of both what are the needs and what they can do. But we know that even though the Americans with Disabilities Act, as you said, has been there for decades, that most physicians don't know what it is or their responsibilities to it. As related to large healthcare systems, such as the one I am, what I hear is that, oh yes, but we don't have the staff or to help them get in the door right now. Our clinic doesn't have the setup or the system to provide that accommodation without proactively thinking, but you're huge. You
Right.
should.
Right.
You're responsible for doing that. And so it requires not just the awareness, but a proactive sense of responsibility and then resources to make it happen.
I'd love to get your opinion on this, your perspective. We recently attended the American Public Health Association's annual meeting, and the theme there for this past year was rebuilding trust in public health. Now, obviously, that runs a wide gamut when you're talking about rebuilding trust in public health coming off of COVID. But do you feel that there is a sense of distrust in the healthcare system that is prevalent among those within the disabled community? And if so, what are the consequences? How does that have a real world effect on somebody who may not be seeking the healthcare that they need?
The issue of trust is very important. There's so much, first of all, that depends on the patient-provider relationship. During COVID, what we saw was while many individuals were seeking out medical care, they wanted more information. They wanted the input and the guidance and the support of the healthcare systems. Many individuals with disabilities were afraid to go there, and particularly because of that ableism. They were afraid, and it had actually happened, that individuals with disabilities were told, your life isn't important. You don't have a quality of life, and so we're going to put you in hospice. We're not giving you access to that ventilator or to these life-saving devices because we have to give this to people whose life is more valued.
So they were considered very low priority.
They were.
Where do we stand now when it comes to trying to rebuild that trust?
I think we're beginning to do that. The Justice Department and really looked at what the civil rights were for individuals with disabilities and said, you can't do that. You can't consider what your perception of quality of life is. It's one thing to set the law, another thing to actually have that implemented. But I do think, here at U of M, University of Michigan and other places, is we created guidelines, visitor guidelines and others, to provide a standard to say you can't consider that. You have to allow advocates into place. You have to, providing concrete recommendations to consider what needs to happen. But that trust is slow to come back. The communities that have a history of experiencing violence by the healthcare system, who have been experimented upon, who have been ignored, who have been, have different degrees of discrimination and bias that they've been dealing with for many years, it's harder. The systematic approaches, protocols and guidelines, the evidence-based practices, and really thinking about what the range of options are and providing them to the patients and being transparent about the concern about what we can do and what we can't do, but not just saying, I'm sorry, that's it. Saying, how can we work with you? Where else may be there?
Yeah, I'm sure there's a feeling of nobody believes me, nobody listens to me, nobody believes what I say.
Too often.
Yeah.
And I think some of that is because, once again, healthcare system is often put as the gatekeeper. We're the ones who almost are meant to decide, does this person have a disability or not? Where an individual in their own life knows, I have a disability or I'm impacted by this, and I'm just trying to do my best.
Yeah, just trying to get through the day. Okay, so we definitely, there is still progress to be made, a lot of it.
Yes.
I think having these conversations are so important to, seeing that progress come to fruition. So as we look to the future, what specific actions would you advocate for the most that you think would have an immediate and significant impact on health equity for individuals with disabilities?
I try and think about health equity from the lens of healthcare equity and what can healthcare systems do, because this disparity is the result of what we do or don't do right within organizations. These are modifiable factors that can be changed. We can think about bringing individuals with disabilities to the table, to make sure that we're talking to them about their concerns. We're making sure that they're involved as leaders, as our providers, and so those voices are amplified, and they're providing automatic and regular audits of their environments and our practices. Then we also need the recognition and investment by those in the C-suite, those in administrative levels, to say these protocols and these policies are important, that this is actually going to improve the quality of care we provide across the board, the safety of our services, and our bottom line when we are aware of the needs of individuals with disabilities, and we invest money in ensuring that they're at the table, they're included, and that our protocols and practices are inclusive of their needs.
Yeah, we really need the ears of those people who can implement those changes.
Exactly.
All right. Well, Professor Meade, thank you so much for speaking with us today and for bringing all of these key points to our attention. And thank you very much for all of the work that you and your team do at the University of Michigan. We appreciate it.
Thank you so much for having us on.
Really, really fascinating interview there with Michelle Meade at the Center for Disability Health and Wellness from the University of Michigan. Really appreciated her weighing in on disability rights and kind of where things stand with legal ramifications. Coming up next time on Equal Dose, we'll be taking a look at addiction and data with Dr. Allison Arwady, the director of the CDC's Injury Center. But until then, Stephen, Laila, it's been a pleasure.
It's been great, Autria. So thank you very much and goodbye.
Bye.
Equal Dose is brought to you by Web's Edge. We'd like to thank researcher Maddie Horn and editor Abby Harries. Graphics were done by Matthew Coleman, and Equal Dose is produced by Kath Sheehan.